blood-retinal barrier as well as blood-aqueous barrier. And so the tissue is accumulated with the lipoproteins, and edema is persistent. As long as the edema is increased and remains there persistent, it loses the function of the tissues. So the inflammation is nowadays a common theory for many retinal disorders apart from the bodies also. Uveitis, you know that the inflammation is the major component. Retinal vein occlusion, almost there are several things. Vascular leakage is common in retinal vein occlusion. Wet AMD, we know that there is a neovascularization component is more. But the diabetic macular edema, as we know that it is a multifactorial. So multifactorial, one component is inflammation is there, one component is neovascularization is there, and third component is vascular leakage. All this is a microangiopathy. All together they are equally responsible for diabetic macular edema. So one component treating means two other components are left behind every time. So if you want to address a diabetic macular edema, all these three components should be taken care of. Nowadays, what is the practical thing was discussing when we were taking tea. The practical thing is that the OCT has changed altogether look out towards the diabetic macular edema. Clinically, it is very difficult unless and until you see some succinic exudates and so many exudations, ARMs and hemorrhages on the macula. Till that time, it is not detectable. But the OCT has made so many miracles or wonders in understanding the pathology of the diabetic macular edema. The OCT is an objective and qualitative evaluation. We will see in detail what is OCT, but it measures more accurate all layers of the retina, where exactly the edema is there and how much is the thickness. You can literally measure. If it is more than 300 micron, then you can label it as edema. Or in clinical terms also, if the vision drops down to 6-9, then again you can say that there is something going wrong in the retina. And OCT particularly helps in early diagnosis, treatment and follow-up studies, which we will see. See this type of thing. A cyst is there. Despite of treatment, you see the laser marks are there. Still the cyst is persistent. Here also we have done the laser. Still the cystic changes are there, which we cannot see directly on even detailed direct ophthalmoscopy or indirect biomicroscopy. Such types of edema. How you are able to see that this is the shape and size of the edema? No, you can't see these types of intraretinal cysts. It is very difficult. So the OCT is very important. See, this is a subretinal fluid. How it is known? This is just in microliters, 5 to 10 microliters fluid is there. But that is producing so much of the visual loss. This patient may not be having more than 660 vision. Same thing after treatment, what happened? You can see that the fluid has been reduced. You can see the various types of follow-up studies with the help of OCT. What has happened in April 18 till this one September 19. There are certainly sometimes there is a response, sometimes marginal response. Then there is again rebound edema, and then you are frustrated. Patient also sees that I am taking the treatment as far as the ophthalmologist suggests. But we know that this is a multifactorial disorders, and particularly in diabetic macular edema, one should always concentrate on the systemic control of the disease, particularly diabetes, hypertension, cholesterol, lipids and other components. Here also you can see that this was a doctor patient which was worried about the loss of the vision, and he felt that he will not be able to read and write anymore, but treatment has helped. See that this is the slide which shows that what are the goals of the treatment in diabetic retinopathy. It is to reduce the amount of macular edema, particularly if it is more than 300 micron, you reduce it. Reduce the leakage on angiography, then reduce the thickness on OCT, and what we are doing all the treatment is to stabilize the vision. We never comment that your vision will come back, your quality of vision will come back, at least stabilize. And apart from that, the success, as we saw that, depends upon what is the kidney status, heart status, lipid status and glycemic status of the patient, what is the HbA1c. If fasting post meal is most of the time normal, but HbA1c is 11, 12, then obviously it cannot be, such types of patient may not respond. Then systemic cause, how this was almost normal in June 18. What happened in December 18. You just see that there is an increase in the exudation, cottonwood spots, hemorrhages, and the patient has having uncontrolled diabetes. Apart from that, he was a hypertension and all. The edema has come, ERMs have been come, and now we know that the prognosis has been changed within a short time because of the systemic factor. There are no local factors which are involved to cause such types of edema. Then what are the treatment options if we come to such types of diseases like C.M.E? If this is the patient has you have diagnosed as a general ophthalmologist also. Once the patient comes to you, the vision is less than 6/9 or 6/12, which was already recorded. The patient is your loyal patient coming regularly. Then obviously you will advise the OCT and see that there is a starting of the macular edema on OCT. Then the treatment goes in terms of either you can do the laser, you can give the anti-VEGF in the form of ranibizumab, Avastin, or steroids like Ozurdex or IVTA, or you can do mix and matches or combined therapy, laser plus anti-VEGF, laser plus steroids, and it doesn't work. Despite of doing this one in sessions, 1 session, 2 session, 3 session of 2 months, 3 months duration, till the disease progresses and there is a epiretinal membrane, then obviously you have to see that the patient can benefit by doing the vitrectomy. Despite good vitrectomy and ERM removal also, it is not assured or guaranteed that his edema will come down. Again, with the systemic factors, we know that which plays more role in case of diabetic macular edema against the PDR. PDR has almost 90% of the times the factors are local ischemia. Once you take care of the local ischemia by doing the laser, convert that ischemia into anaxia by doing the laser, one-time treatment, the neovascularization process will be halted to certain extent. But the systemic, his kidneys are not functioning, he is on dialysis, his creatinine is high, his lipids are not controlled, diabetes, heart disease, and all those things, almost duration of the disease, which cannot be reduced by any means. These systemic factors are playing a role in case of diabetic macular edema. So the treatment is also, as we have seen that it is a multimodal. Multimodal means you have to see the patient's general conditions, local conditions, and what it responds. If it responds very well to the anti-VEGFs, continue that way till you find that it is no more responding or partially responding. Then add one more thing. Either you can add the laser, add the steroids, and see what happens, or change the anti-VEGFs from Avastin to ranibizumab, sometimes ranibizumab to Avastin, and it also gives you surprisingly good results. Then what are the things? Now this is the disease of lifetime. Once you label it is a diabetic macular edema, you should be prepared. You don't ask the patient to be prepared first. First you should be prepared as a treating surgeon. Now this patient is your liability till he dies. As long as he is not finding some another retina person. Till that it is your liability. Because he is very loyal till you treat it nicely. Then obviously there are certain things you should have a roadmap of his treatment, what type of his lifestyle is, what is he is obese, overweight, all those things. Apart from that general condition, you should see the local. This kundali should be ready on the day he presented to you, and tell him that this is the future and these are the likely outcomes or likely future of your eyes and vision. After 6 months this will happen, 1 year this may happen, and what will happen if you keep under the systemic condition under control. Now there are certain theories also. People are not doing the laser. People feel that the laser is useless. Then whether it is a redundant in case of diabetic macular edema. What is the end point of anti-VEGF? Every month, 2 months you are injecting. What will happen? How long I can give? How much I can spend? I am already pensioner or I don't have any assistance from anybody, from my children and government also. Will laser add to reduce anti-VEGF? These are the common questions. What is the ideal situation for steroids? How does one reduce therapy course? Means you can increase by 6 months, 3 months, or you can do as a PNR as and when it is required. All these are the questions in the mind of a treating person. These are not the questions of patients only. The treating doctor as well as the referral. Most of the time, the referral also want to know that what happens to my patient. Then these are the theories where particular DRCR net protocol has been found. They are found that instead of going all these slides, how many injections are required. They have done the studies for the diabetic macular edema. In first year, if 8 to 9 injections have been given. Second year, you require 2 to 3 injections. Third year, 1 to 2 injections. And they found that at the end of the 5 years, you may not require the injections and disease can be reverted. And that is what the conclusion. Now you can see that this many injections and all those costs involved. If someone is really ready, absolutely advised, don't hesitate. You are not paying from your pocket. If someone is paying somewhere else, if his marriage is there, so many marriages and all those things, they are spending so many lakhs and show the status and prestige in doing such notorious things, and they are blind at one fine day. Tell them that clearly this is the thing which is required for you, and if you go for this one, obviously your next 13-15 years of the life is assured, at least visual life is assured. But just thinking that why should I, this is the common thing, every month it is required and मग इतकं लागणार करणार आहे मला आत्ताच नको. This is the common thing, you despite of having financial availability, the people reduce reluctant because of the psychology. You have to counsel at this moment only. These are the theories. If you opt, that is good thing. Then there are the steroid theories are there because of the inflammatory nature of the disease. These are also helping, particularly the Ozurdex and Fluoxetine. These are in the pipeline, but they work very well. We know that another component of diabetic macular edema, where you may not be of much help, is the ischemic maculopathy. You can see that this is the normal network of the macula. Wonder is that this gives you a vascular zone, gives you the infinite vision, near, distance as well as color, contrast, and this is 500 micron. This is the best camera in the world. If this is in the humans, you can just imagine what will be the depth and the quality of the camera of eagles and all other animals which are seeing in the water. That is where the humans are still struggling for developing such types of cameras. Then there are types of maculopathies. This can be focal maculopathy, diffuse maculopathy, mixed type of maculopathy, or ischemic type of maculopathy. These are the 4 types of diabetic maculopathies, which altogether called as a diabetic macular edema. Sometimes it is called as C.M.E. There can be names different. On the clinically C.M.E, on angiography it is different, OCT is now classification is different. But for the general ophthalmologist, you should know that how to know the maculopathy. It is a focal maculopathy, means something focus is there. This is the microaneurysm. Around it there is a circular stream. It is abnormal. What is a microaneurysm? Is the abnormality in the capillaries, particularly. That they are not following its osmolarity of sustaining or withholding the contents of the plasma. So they are liberated out. These lipoproteins are liberated out and in the form of succinate. So it is very easy to treat also while doing the lasers. You have to just take care of these microaneurysms. Shoot it, burn it, they will stop leaking. Here also you can do the laser in the form of grid here. Here also you can do the focal lasers, particularly in the succinate. Here also you can do the lasers. The problems comes in, you know that there are certain good results. So after, how to know that? After laser you get the good results and there is no leakage after doing the lasers. But there are limitations of the laser. Everywhere you cannot do the laser, and every time you cannot repeat the laser also. It is a damaging technology, particularly with certain benefits, risk versus benefit. There are certain risks also and benefit. We have to equate it, where you can do the laser and how much laser is allowed, particularly, and how strong laser is allowed. You are not supposed to do the very heavy burns here. Very light burns are required. Particularly there are yellow color wavelengths which are much helpful in the macular area. So if the exactly beneath the fovea the edema is there, you cannot treat these microaneurysms, or you cannot treat the perifoveal microaneurysms which are leaking. How you can manage with the laser? It is not possible. But nowadays with subthreshold or micropulse laser, you can still attempt, particularly after trying everything. If you have tried 5-6 injections and surrounded grid laser and still the edema persists, then dare to treat near the macula or beneath the macula. That is the last option with the laser, not the first one. With that too also yellow micropulse. Then there can be a microaneurysms in the papillomacular bundle. Obviously, papillomacular bundle you cannot do the laser, particularly heavy laser is not allowed. Here you cannot do. That is the limitations of the laser. Then comes the diffuse macular edema. Diffuse macular edema is equal to systemic disorder, uncontrolled, or this is to be noted down. This usually is not an ocular, exclusively an ocular finding. See here the diffuse edema. Such types of lipids exudating means this type is particularly, you can say that this is the executive type of retinopathy. Then exudation comes from where? This is a generalized abnormality of the vessels. That may be particularly uncontrolled diabetes, uncontrolled blood pressure, and serum creatinines are responsible for exudations. The vascular component, which are now controlling the things of the circulation, are disturbed because of the general thing. Everywhere it is there. You can see the pedal edema, breathlessness, dyspnea, and all those things. All these are accompanying with this one. Then if such types of edema is there, then how to treat? You don't jump directly if it is a diffuse macular edema. Diffuse macular edema don't directly jump onto the laser. Particularly nowadays, you see on the OCT how much is the thickness of the macula, central macular thickness, how many cysts are there, is there associated ERM. Then first treat with the anti-VEGF, let the edema come down. Apart from that, give the substantial time or sufficient time to the patient to control the systemic things. Then do the laser. Otherwise, laser is equal to inflammation, inflammation is equal to worsening. This is very simple things and simple language I am explaining for the general appliance now. So don't jump, even though it seems to be very simple and risk-free. The risk associated with this one are much more. Because long term, you know that you cannot reverse the laser. You know that there is a reversal of the anti-VEGF, there is a reversal of the steroids. The effects will vanish once its half-life is over. But laser you cannot reverse. These are one time. Then such types of things, as I already told that, till the edema is subsided, you keep on giving the injecting, and then you can see the wonders of these drugs. If they are responding to the anti-VEGFs. Most of the time we have seen that there are three factors: inflammatory, exudative, as well as ischemic components. If this is the inflammatory component is more, it will respond to the steroid. If it is a leaking more, it will respond more to the anti-VEGF. And this is seen only with one shot of injection. With the one shot of injection, you come to conclusion that how will be the behavior of this patient. Try anti-VEGF and see how much it has responded. If it is responded very well, then further course is very simplified. Next time, just go back and see your OCT pictures. What was it to start with and how it has responded. Then continue with the anti-VEGF, don't disturb with the steroids and other things. If it is marginally responded or not responded or rebound edemas are occurring, then go for the systemic evaluation as well as change the drug. Go into the trial of steroids. Then see what is response. If it has responded very well to the steroid, then you should feel that the inflammatory component is more than 70-80% and VEGF component is less. So it has responded well to the steroids. Now find out the cause of inflammation in its body and treat it apart from the ocular thing. And then you see that these are the very well responding things. In one injection, if it has come down, then continue the injections. See that this is date wise what happens to the edema and all those things. This is a wonder, and even though you have seen that this is a 20th August and 29th September, you are at almost 1.5 months. But if you record it, if the patient comes back, within 48 hours also you will see that such types of wonderful results are achieved in many cases. This one also you can see 5th of November this was like this and 18th of November means within 11-12 days the edema has gone down, and that is with the single shot of the injections. And one more thing that I have just told you, that you should know the kundali of the patient, and these are very loyal unless and until you want patient to go somewhere else. This is a very situation, tricky situation. So keeps on coming, and then the responsibility, even it is more than that, and follow-up is there. So what happens that the patients are very loyal unless and until we always say that they are shopping and all those things. This won't happen with the good people. That is very sure. I know that unless you say something or mishandle the patient, he won't leave you. Then the responsibility is rest 100% on you. They are ready to do anything. Doctor sahib तुम्ही सांगा मी करायला तयार, and they are very sincere and all. Then what is the wrong? Science is limited. You can't say like that. Keep on treating and say that what best can be done in these cases. Then and then only the patient knows that you with the bottom of your heart you are thinking on him and treating, and then they will remain. This is the pre-treatment, post-treatment, such types of things wonder occurs, and keep on, because this is, you are not responsible for the disease itself. The diabetes is because of his ancestral or genetic inheritance to him, and this is producing a side effect. Your job is in mediator to treat in between God and the patient. Every time show him that this was the result happened, this was a pre-existing, and it's very easy on the screen to show that this was the thing, the injection after this happened, and if rebound edema occurs, then also you should tell him that this is happening and I am not responsible, we are treating ourselves very well. If the combined situation is there, the PDR with vitreous hemorrhage and C.M.E, then obviously you have to address with the anti-VEGF, which will work for the both. If it is a mixed retinopathy, you should treat with the anti-VEGF first. Then this is the role of the steroid versus anti-VEGF. Steroid has pan anti-VEGF, while as VEGF will act only on the VEGF, but steroid will act on other inflammatory components also which are producing the edema. So most of the times where the patient general conditions are not good, you can try the steroids unless and until contraindicated. The only side effect of the steroids, local side effect, is the development of the cataract and glaucoma. And that if it is not there, if it is pseudophakic and patient is not a steroid responder, then you can try the steroid. They are very cheaper and helpful also. And you know that this, just for the sake of information, the potency of the steroid, dexamethasone, betamethasone and triazonolone are the highest potent steroids. This is a pre and post Ozurdex, you can see, pre and post Ozurdex, and here you can see that these are the results of treatment. And we, as a general ophthalmologist who have operated the diabetic patient for the cataract, for even despite of good cataract surgery, the cystoid macular edema is very common because of the systemic derangement particularly. Your surgery is very excellent, you have done all surgeries equally, but the diabetics usually give surprises of cystoid macular edema. So these types of things can be managed with IVT or subvenous Kenacort. Then vitrectomy is required, particularly ERMs, macular hole associated with the diabetic macular edema. Then it can be taken care. If it is a TID associated with, then obviously the surgery is the first line of treatment. Then rebound edema, you can show it only when you have documented very well and explained. You don't take the responsibility of rebound edema on your shoulder. Either place it onto the nature of the drug itself or the nature of the disease. And this is rebound edema. You can see that what happens with the rebound edema. You can document it very well. It was reduced with the steroids or whatever the injection you have given, but it has again come, and tell that this is the ERM responsible for that. If you are fit for the surgery, obviously we will do the surgery. Particularly such types of rebound edema is coming up, means general condition is not under control. You can operate very well, yeah, as good as other patients, but your results will not be good again. Despite of good surgery, the edema will again come there. So these patients we have not taken for the surgery, particularly because they were not systematically controlled diabetes and others. Then these are the pre and post. There are certain situations in diabetic maculopathy, particularly you can see that these are the hard exudate crystals. Crystals have been formed intraretinal, and you can see that the shadowing there, shadowing is there. Crystals and shadow means already the damage has been irreparable stage. Whatever it is possible, you can maintain. You cannot go inside the retina and remove those crystals. Then when to give eccentrics and when to give the ozodic. See, there is no subretinal fluid. Subretinal fluid means the level of the inflammation is so high that it has gone behind the retina also. So here the role of anti-inflammatory, particularly steroid is there. This is a thumb rule, it is not a hard and fast rule. Even certain cases, anti-VEGFs also work. Where it is a spongy edema, the regular anti-VEGFs can be tried. And there are very many cases which are mixed type of retinopathies. You can try possible treatment and hope for the best. In conclusion, diabetic macular edema is not at all preventable and there is no complete cure. This is my conclusion as well as many experienced people who are facing such types of patients. Patients' diabetic status cannot remain at an euglycemic state throughout. So it keeps on coming and going. What can be done is early detection and treatment matters a lot because you cannot reverse the 100% load, but 10% load you can reverse it. That time patient's education and systemic conditions can be counseled properly and there you can get the good results if you detect early. And early detection nowadays, you know that doing simply OCT. Patient vision has gone down to 6/9. No reason to keep it with you, or if you are having OCT, do it and find out what is the reason for the low vision. If it is because of macular edema, then obviously it can be taken care immediately. There should be good communication among all concerned healthcare personnel. All healthcare personnel, including you, me, and all general ophthalmologists, diabetologists, physicians, dietitians, and so many things. There are so many subspecialties or branches in this, even endocrinologist. To understand the physical and psychological stress of visual loss of the patient because of diabetic macular edema, we